Good morning, dear chair, dear audience. Let me present you my PhD thesis work, which is Impact of Uterine Surgeries on Clinical and Reproductive Health. My name is Lőrincz. I'm a medical doctor and a PhD student at the Department of Obstetrics and Gynecology at Semmelweis University. And my vision are women without postoperative complications after uterine surgery, and my mission is to find uterine surgical techniques with the least amount of complications. Right now I have two ongoing projects, and I would like to present the first one, which is investigating the efficacy and safety of different cesarean section layering techniques. We know that cesarean section rates continues to rise worldwide, right now accounting for more than 1 in 5 of all childbirths. And we know that this rate in Europe is even higher, and it is estimated that by 2030, nearly a third of all births will take place via cesarean section. The cesarean scar defect is an underestimated pathology due to the clinicians' unawareness, and can be detected in more than 50% of women with a history of cesarean delivery. It can have many potential complications, ranging from infertility to placenta disorders, scar ectopic pregnancy, and uterine dehiscence or rupture. Single or double layer continues to remain a topic of debate because clinical outcomes are lacking. Our aim is to compare different layering techniques and assess the complications in post-C-section women. Our clinical question is, does double-layer cesarean section closure technique result in a lower incidence of complication compared to single-layer closure? Our patient population were post-C-section women divided into two categories, those with a subsequent pregnancy and those without. Our intervention was a double-layer closure technique. The comparison was a single-layer closure technique. And as outcomes, we chose complications like the presence of the scar defect, the measurements of the scar defect, maternal infectious morbidity, procedural details of the delivery, length of the hospitalization, and so on. We hypothesized that double-layer technique results in lower incidence of complications compared to the single-layer technique. Here, we conducted our systematic search in these three main databases, and you can see our search key, which consists of two domains. The first one refers to the cesarean section itself, and the second one to the suturing. Our search key resulted in more than 9,000 articles, and after the selection and the citation chasing, we are left with 35 articles. So our first outcome is the cesarean scar defect at the 6 weeks follow-up. We compared the double-layer closure with the single-layer closure technique, and we made subgroups based on whether they used locked or unlocked sutures. As a measure of effect, we have odds ratio measuring 0.95, which means that the cesarean scar defect was slightly more common in the single-layer closure technique, but not in a clinically significant way. Our next outcome is a cesarean scar defect at 6 to 24 months follow-up. And once again, we compared the double-layer closure with the single-layer closure. And here the odds ratio was 0.67, which means, again, that it was slightly more common in the single-layer closure, but not in a clinically significant way. Our next outcome was a uterine dehiscence. Here we see that, once again, it was more common in the single-layer closure, but we see the same tendency in the subgroups as well. And although it did not reach statistical significance, it still remains highly relevant clinically. And when it came to the uterine rupture, we know that we have a high heterogeneity and odds ratio of 0.62, which means that, again, it was more common in the single-layer closure, and it did not reach the statistical significance, with the exception of the first subgroup where they used lock sutures in both layers. And here we know that the uterine rupture was 83% more common in the single layer group, which is clinically highly relevant. Our study has strengths and limitations. As strengths, we can mention that we use RCTs, which lead to the highest level of evidence. We have a high patient number, a rigorous methodology, and as a limitation, we can say that we had high heterogeneity. Our conclusion is that double-layer suture decreases the risk of uterine dehiscence and rupture in subsequent pregnancies. As an implication for practice, we would advise surgeons to use the double-layer technique, providing a safer condition for subsequent pregnancies. And as an implication for research, we can say that more RCTs and cohort studies with different subgroups based on parity and previous cesarean section numbers are needed. This is the progress of my first project. We are done with the manuscript, and I'm preparing to send it to internal review. And after that, we would like to submit to the American Journal of Obstetrics and Gynecology, which is a human journal. My second topic is comparing different cervical ripening methods and optimizing neonatal and maternal outcomes. So we know that the prevalence of labor induction in Norway increased from almost 10% to 26% during 1999 and 2019 in pregnancies in gestational week 37 and beyond. Mechanical methods and chemical agents are widely used to prepare the cervix for labor, but we know that the chemical-only method can have the risk of uterine tachysystole, and the mechanical method can prolong the induction to delivery interval. And it seems that combined method can lead to more balanced outcomes. Our aim is to evaluate the efficacy and safety of combined cervical ripening and improving maternal and neonatal outcomes compared to chemical-only ripening. Our clinical question is, which cervical ripening method has better neonatal and maternal outcomes or less complications? The population were patients with a viable singleton fetus and unfavorable cervix undergoing labor induction. Our intervention was mechanical plus minus chemical ripening, and the comparison was the chemical ripening only. Our outcomes can be divided into maternal and neonatal outcomes, such as the frequency of vaginal delivery, induction to delivery interval, uterine tachysystole, and the neonatal outcomes such as fetal heart rate abnormalities, Apgar scores, NICU admissions. We hypothesized that the combined ripening technique has a better neonatal and maternal outcomes. And as a clinical implication, we would like to help clinicians in the personalized decision making. Here you can see our preliminary search key, which also consists of two domains. The first one refers to the labor or the birth itself, and the second one is the chemical agent. These are our preliminary results in the databases, and I'm preparing to submit the PROSPER registration for my second project. In summary, here you can see both of my project and their planned submission dates, which are January and August 2025. I would like to thank you for your attention. With the words of Thomas Berger, the art and science of asking questions is the source of all knowledge. Thank you.
Thank you for the great presentation. I would have a question to the first project. And you had a first plot about the cesarean scare defect after 6 weeks.
Yes.
But what do you think about this follow-up period? Because according to my clinical practice, at the 6 weeks ultrasound, everyone has a scar defect.
Yeah, and as you had the chance to see, there weren't a lot of articles which reported after the 6 weeks. We wanted to see if there's anything special about it, but turns out like there wasn't. I don't know. So basically, yeah, everyone.
But does it mean a niche at this period? So the definition of the scar defect was the same as later?
Yes, and I mean, in some cases, they defined like an unechogenic area at the site of the cesarean scar of at least 1 millimeter, or in some cases 2 millimeters depth. So yeah, it was kind of the same, but it also varies a lot. I mean, 1 millimeter is not a lot, but
okay. Thank you for your answer.
Okay, I also have a question. Actually, I just had the exact symptoms like Bogi. So about this 6 weeks period, and I wanted to ask you that did you actually check it after this niche, and also maybe those patients who actually have complaints in the future with the niche, or because you were referring here only for the 6 weeks one, right? In the if I'm right, when you were examining, it was only the 6 weeks ultrasound.
Yeah, the first forest plot was the 6 weeks, and in the second one we had from 6 months to 24 months follow-up.
But it was the patients with who had ultrasound diagnosed niche only, or they actually had complaints? Or you have no information about that?
I do not have information about it. So.
Okay, thanks. Because I think that would be also interesting to know, because I mean we see many times. These scars. And I have for your second project, I also have a question that what kind of agents did they use in these articles for chemical ribbonning?
What kind of agent?
What kind of drugs?
Yeah, so I haven't had the chance to look through it thoroughly yet, but I will see. I don't know.
Okay.
I cannot answer that.
Thank you very much.
Thank you.